طيب بسم الله الرحمن الرحيم. في البداية السلام عليكم، مرحب بالجميع. أولا يعني صراحة it's an honor إنه يعني زول يكون participant في ال Sudanese Surgical Club Lecture Series. بتذكر لما كنت medical students يعني one of the lecture that I've never missed كان ال Surgical Club في الجامعة. ف it's an honor. مرحبا بكم وشكرا على الفرصة. شكر خاص للمنظمين محمد عباس في السودان وأكرم بهنا. صراحة ما قصروا يعني they made it very easy. كل اللوجيستيك support كان it was very easy to set. العتبة الوحيدة إنه اكتشفت الليلة إنه خدتوني في النص بين لكشر دكتور ابن عوف امبارح ولكشر بروفيسور رشيد بكرة. فشكرا أكرم محمد على الحاجة دي. شوية عن نفسي. أنا حسام جلال، معروف في السودان حسام جلال، هنا في أمريكا حسام عثمان. تخرجت الخرطوم 2005. جيت أمريكا هنا عملت السيرجيكال ريزيدنسي في أوهايو، fellowship في Hepatobiliary and Foregut Surgeon في دالاس تكساس. أنا حاليا practicing surgeon في دالاس تكساس Hepatobiliary and Foregut والassociate director of the Hepatobiliary fellowship. الليكتشر الليله حيكون عن الاكيوت pancreatitis والمانجمنت of acute pancreatitis. الليكتشر حيكون mostly regarding the practical and the patient management aspect اكثر من انه يكون يعني review of data or literature. نحاول نخليه interactive زي ما قال اكرم. لو في زول عنده اي سؤال في نفس الوقت يعني I'm gonna try to reach out to you guys انه نشوف الحاجات اللي بتتعمل في السودان شنو يعني so we can transfer the knowledge من هنا للسودان وبرضه من السودان لهنا from the clinical aspect. فبسم الله نبدأ. To start with, management of acute pancreatitis is a multidisciplinary approach, meaning that it's something that requires a lot of physician, a lot of discipline to participate in that. And this is one thing that I really enjoy about pancreatitis and developing pancreatitis program, that it will force you to have a strong infrastructure. يعني لو انت داير يكون عندك program to manage pancreatitis patient، الحاجة دي automatically will force you انك انت to build your infrastructure and to build multiple departments في الhospital حقك. Something very similar to trauma. It will force you to improve on multi-level. For example, the last patient that I had with severe necrotizing pancreatitis, I had multiple physicians helping me with that patient. I had our hospitalist, the medical doctor. I had our intensivist. The patient was on a mechanical ventilator for respiratory failure. He came in with acute kidney injury and it was in renal failure and requiring dialysis. I had our gastroenterologist helping me with an ERCP patient who was a biliary pancreatitis and came in with an impacted stone in the bile duct. He had other medical problem and cardiac issue, and I had our cardiologist helping me. My interventional radiologist was played a crucial part in managing this patient. I eventually ended up operating this patient for an open neck resectomy. Just to give an idea how multiple physicians will need to be involved to make sure these patients are treated correctly. So the question, why do we talk about pancreatitis? What are we trying to do for this patient? And the answer, the reason we need to talk about that is because severe pancreatitis has a mortality of 10 to 30%. So it's a serious disease. The question is, what is severe pancreatitis? How do we define severe pancreatitis? So عشان ما نبقى زي بابل وإنه كل زول بيكون بيتكلم لغة مختلفة, we need to identify our terminology. We need to know, so when we say something, we need to know, all of us need to understand exactly what are we talking about. There have been multiple attempts to define terminology in pancreatitis, but we're going to focus on the one that we are currently using, the revised Atlantic classification. The revised Atlantic classification, based on its name, happened in a conference in Atlanta in 2012, and the results were published in 2013. هتكلم عن حاجتين في الديفينيشن والترمينولوجي. هنتكلم عن التايب of pancreatitis والتايب of fluid collection. الحاجة دي هتكون مهمة for the rest of the lecture لأنه كل مرة لما نستعمل terminology, this is what we mean by that terminology. فعندنا two types of pancreatitis based on the revised Atlantic classification. The first one is the interstitial edematous pancreatitis. Based on its name, clearly it's defined as a lack of pancreatic parenchymal necrosis or peripancreatic necrosis on imaging. There's a diffuse inflammation of the pancreas with maybe peripancreatic inflammation and fluid, but there is lack of necrosis either in the pancreas or outside the pancreas. 80 to 90% of the pancreatitis that we see are interstitial pancreatitis, and they usually resolve quickly over the first week. The other type of pancreatitis is a necrotizing pancreatitis. Simply, there is a necrosis either within the pancreas or outside the peripancreatic tissue, or both. The other part of the definition is the fluid collection, and this is where most of the confusion happens. لأنه مرات كثيرة بتسمع العيان ده عنده pseudocyst، أو العيان ده عنده necrosis with fluid، أو العيان ده عنده pancreatic phlegmon. First of all, the terminology phlegmon is rarely used now. So now we use acute peripancreatic fluid collection, acute necrotic collection, pancreatic pseudocyst, and walled-up pancreatic necrosis. وحنجي مارين على الترمينولوجي والدefinition, so we are all on the same page. So acute peripancreatic fluid collection, by definition, this is a patient who has an interstitial pancreatitis. There's no necrosis, absolutely no necrosis. So in the first 4 weeks of acute interstitial pancreatitis, if you have fluid collection around the pancreas, usually it's an amorphous fluid collection. There's no wall because it's still early on. We call this collection acute peripancreatic fluid collection. If these fluid collections persist after 4 weeks, they will mature and develop a wall, and then we call them pancreatic pseudocyst. Pancreatic pseudocyst is a term that we use a lot and all the time. He has a pseudocyst. There's a pseudocyst. In reality, a true pseudocyst is very rare. It is very unusual to have a pancreatic pseudocyst, meaning an acute peripancreatic fluid collection that had persisted and matured into fluid collection without necrosis or debris. It's very rare to have that. We see it rarely, but this is the true definition of pancreatic pseudocyst. The other type of collection is the acute necrotic collection, which again, it's an acute process. This is a fluid collection that happened in the first 4 weeks of acute necrotizing pancreatitis. And we see that on CT scan, these patients have solid or necrotic material. As you can see here on CT scan, you can see that the body and the neck of the pancreas are necrosed and they're not enhancing on CT scan. And you see the fluid around them. So these are acute necrotic collection. When the acute necrotic collection persists after 4 weeks, they developed a wall. And then we call them walled-up pancreatic necrosis or WAPN. And again, they're mature encapsulated acute necrotic collection. Okay. So this is the terminology. We have interstitial pancreatitis. We had acute and necrotizing pancreatitis. We have 4 definitions of fluid collection. With the interstitial pancreatitis, the first 4 weeks, we have amorphous fluid. We call that acute peripancreatic collection. After 4 weeks, if it matures and forms the wall around it, it's a pseudocyst. With acute necrotizing pancreatitis, it's an acute necrotic collection. If the collection persists after 4 weeks and form a mature wall around it, then it's called walled-up pancreatic necrosis or WAPN. The other thing we just said severe pancreatitis is very important because 10 to 30% of people will die. How do we define the severity of acute pancreatitis? The revised Atlanta classification identified 3 degrees of severity. We have mild acute pancreatitis, we have moderately severe acute pancreatitis, and severe acute pancreatitis. الفرق بين الثلاثة ديل will depend on the presence or absence of persistent organ failure and local and systemic complication. لما نعرف في السلايد دي هتلقى انه mild acute pancreatitis, there's no organ failure and there's no local or systemic complication. ديل العيانين اللي بيجوا للحوادث او emergency department, majority of them with acute pancreatitis, and it does resolve within a week or so. The other type is the moderately severe acute pancreatitis. دول العيانين اللي بيجوا ب organ failure that resolve within 48 hours. So it's a transient organ failure and or local or systemic complication. Infection, pleural effusion, any systemic or local complication, bleeding, we call them moderately severe acute pancreatitis. The other one is the severe acute pancreatitis is defined as a persistent single or multi-organ failure for more than 48 hours. So mild acute pancreatitis, no organ failure, no local or systemic complication. Moderately severe, transient organ failure, and or local or systemic complication. Severe, persistent organ failure for more than 48 hours. التوبيك الليلة حيكون focus على severe and necrotizing pancreatitis, meaning that we're not going to talk about mild acute pancreatitis. We're going to talk about the moderately severe and mostly the acute pancreatitis. عشان نقدر to manage the patient with severe pancreatitis, usually what I tell the patient or the family when I see them with severe pancreatitis is bear with us. This is going to be a long process because severe pancreatitis will tend to come in phases and stages. Phase 1, and these phases are this is rough estimate because there's a lot of overlap between the phases. Just because we say something will happen in phase 1 does not mean that it may not happen in a delayed fashion in phase 2. Just because we say something that something will belong to phase 2 does not mean that it will not happen in phase 1, if that makes sense. Like in generally speaking, phase 1 is usually the first 3 to 4 weeks. Usually it's a manifestation of SIRS, systemic inflammatory response syndrome, and organ failure. Phase 2 بيحصل بين the 3rd to the 8th week. لسه بكون في organ failure sometimes, but this is the phase where infections happen. It's very unusual for us to see infected pancreatic necrosis in phase 1. And that's important when it comes to the management of these patients. But in phase 2, we see subacute complication or presentation, I should say, in terms of infection and local complication, and we may see persistent organ failure. Phase 3 is a delayed phase, few months after that, and usually this is when they have a structural damage within the pancreas. This is when they present with a symptomatic wall of pancreatic necrosis, what people usually call a symptomatic pseudocyst, or when they have a disconnected duct syndrome or recurrent pancreatitis attack because of structural damage. Today we're going to focus on phase 1 and phase 2. Phase 3, I think it belongs more to the chronic pancreatitis management, but we can talk about it briefly if we have time at the end. So in phase 1, what we need to do, we need to make sure that we diagnose the pancreatitis correctly. We need to identify the etiology. We need to assess the severity. We need to understand that in phase 1, we're mostly dealing with SIRS and organ failure, and the treatment for that is generally supportive care. So before I go into this slide, Muhammad, لو سامعني? Currently, how do we make the diagnosis of pancreatitis? If a patient presents to the emergency department, how do we make that diagnosis?
Clinically, according to the history examination, baseline investigation, blood investigation.
Okay. Revised Atlantic classification want us to use 2 of the 3 following features to diagnose pancreatitis. واحد, classic pain, اللي هو central abdominal pain radiating to the back. Classic presentation, classic pain. Second, serum amylase or lipase greater than 3 times the upper limit of normal. 3, characteristic feature on CT scan. Any 2 of the 3 will make the diagnosis of acute pancreatitis. So, Al-Tani Muhammad, how feasible or available CT scan في السودان حاليا؟
موجودة في كم مركز معظمهم برايفت سنترز.
اوكي.
الخرطوم.
طيب العيان لو جاء حوادث ببانكرياتايتس هل feasible انه الناس تعمل لهم CT scan ولا does it takes effort of time عشان الناس يعني
المشكلة الأساسية إنها ما بتكون موجودة في نفس المستشفى، إلا العيان بيضطر إنه يمشي مثلا بالإسعاف لسنتر فيه سي تي سكان.
اوكي كلام جميل جدا. حاليا البراكتس في امريكا هنا انه you don't need a CT scan to make a diagnosis. People will rely on the central abdominal pain and they will rely on the serum amylase and lipase greater than 3 times the upper limit of normal to make the diagnosis. You have these two, you have a diagnosis of acute pancreatitis. And they reserve the CT scan for people who have severe pancreatitis لأنه أغلبية التغيرات في السي تي سكان النيكروزز الفلويد collection الحاجات دي بتحصل 48 hours after presentation. So a CT scan on presentation will rarely help you with the severity. في Dallas هنا احنا يعني we use the CT scan a little bit more than other parts of the country for multiple reasons. One, we use it sometimes to rule out other diagnoses. Second, we still get CT scan for anyone above the age of 40. The reason for that, we want to make sure that we do not see a mature cyst when we do a CT scan on an initial pancreatitis presentation. محمد سؤال ممكن ترجع السؤال ده لأي زول عندك هنا في الشات. Why is it important that we don't see a mature cyst or mature fluid collection on presentation for the initial pancreatitis attack?
ممكن لو في زول عايز يجاوب يا مستر، كل الناس بتسمع، ممكن
جدا.
في زول يعمل ميوت.
داير اسمع صوت الناس. Any takers?
Just a little interaction in Nuyahi معكم أكرم. The questions are, the purpose of the questions are just to kind of understand what's the local practice. ممكن حتى يعني juniors or seniors help kind of make the understanding of how things are going in Sudan.
Exactly. طيب ما مشكلة.
أنا I think you need to exclude the cystic pancreatic neoplasms دي واحدة منها يا حسام.
Exactly. To exclude a cystic pancreatic neoplasm. That's exactly correct. عشان كده ناس above the age.
أيوة. دي أهم. أنا I just like the way you divide الphases دي. Just go on. تمام حلو شديد.
يديك العافية. لأنه في in the initial pancreatitis attack لو عملنا CT scan on presentation and we see a mature cyst, that cyst is not a result of pancreatitis. The likelihood that cyst is what caused the pancreatitis. The importance of that is that زي ما سمعتوا we're likely dealing with a cystic neoplasm, pancreatic cystic neoplasm, namely IPMN. When IPMN present with pancreatitis, that's a worsened feature, and العيان ده غالبا will need surgical resection down the line once their pancreatitis resolved. Well, importance بتاع IPMN, we don't want to talk a lot about pancreatic cystic neoplasm today. If we miss a pancreatic cystic neoplasm that's symptomatic, especially main duct IPMN, we are likely missing a future pancreatic cancer. That's the importance of making sure that we do not see a mature cyst on the CT scan at the initial presentation of pancreatitis. And that's the reason why still in Dallas we do CT scan on patients who present with pancreatitis who are above the age of 40.
يا حسام.
أيوة.
كان في محمد علي رافع يده. عندك سؤال محمد؟
تفضل محمد.
برضو ولا هذه كانت قالت نفس الكلام من
لا شكرا جزيلا. أنا بس كنا بس نشارك معكم وخلاص نفس الإجابة. شكرا تسلم.
يديك العافية.
Thank you.
Next step is when you manage the patient in phase 1 is to identify the etiology of pancreatitis. في أمريكا هنا بيحبوا الأكرونيم I get smashed. وأكرم تصلحني لو غلطت في واحدة ديل. Idiopathic, gallstone, ethanol, which is alcohol, trauma, steroid, mumps and viral infection, autoimmune pancreatitis, steroids or scorbine, if we said steroid already, hypertriglyceridemia and hypercalcemia, ERCP, and drugs. Did I miss anything, Akram? شو الرز تطور عليه. تمام. So you guys know this. الحاجات straightforward, the simple, and we can find it easy in the book. We're just gonna go quickly over it. هنحاول نركز على الحاجات اللي فيها مو يعني patient care and practice guideline. الحاجة after we make the diagnosis and after we identify the etiology, and identifying the etiology is important. If it's biliary pancreatitis, you have to keep in mind that gallbladder will need to come out at some point. If it's triglyceride, you need to make sure that you treat that so the patient does not develop recurrent pancreatitis. That's why identifying the etiology is important. Alcohol, you have to stop drinking alcohol, of course. الحاجة الثانية اللي بحب أذكر الناس في الetiology, smoking. Smoking does not cause pancreatitis, but smoking will make sure your pancreatitis does not go away. لما يكون عندي عيان recurrent pancreatitis or chronic pancreatitis, I will ask them to quit drinking. لكن most importantly, I would ask them to stop smoking. ما عندي مشكلة إنه العيان يكون لسه في أمريكا هنا they drink a little bit every now and then. لكن I want them absolutely to stop smoking. Whatever intervention you do for pancreatitis is not going to work as long as the patient will continue to smoke. Meaning that smoking does not cause pancreatitis, but smoking will make sure that your pancreatitis does not go away and it doesn't get better. دي بس مراجعة تاني للكلام اللي قلناه لأنه definition of severity of acute pancreatitis. قلنا عندنا mild acute pancreatitis, moderate severe and severe pancreatitis. قلنا كيف بنقدر نفرق بيناتهم. So again, this is important لأنه mild acute pancreatitis has expected complete recovery within 1 week, less than 1% mortality. Majority of the patient that we see, 80 to 90%. لكن a severe pancreatitis has mortality of 10 to 30%. Okay. An assessment of severity is important لأنه بحدد allocation of the care of this patient. Meaning that when we see patient with pancreatitis and we think this patient is going to have a very bad severe pancreatitis, he's going to be one of those 10% that's going to get really sick with infection or with organ failure. This is the patient that I will need to put the intensive care unit, or this is the patient that I will need to transfer to a tertiary center. سؤال للجروب حاليا في السودان, how do we do that? How do we assess severity? How do we decide which patient is going to get admitted to a small hospital, which patient will need to be transferred to a higher level care? How do we do that حاليا في السودان? Any takers? أكرم ومحمد لو شايفين أي زر رافع يده, please let me know.
أكيد ما شايف زر رافع حسين.
Okay, we're gonna move ahead. الحاجة ممكن أقول لكم إنه هنا عندنا في أمريكا لسه we are not, we don't agree on a single scoring system. في multiple scoring system and multiple way to assess severity of pancreatitis. Remember, when you assess severity, we're trying to predict who is going to get sick and where to put them and where do we treat them. الحاجة المعروفة الرانسون's criteria. يعني I'm not sure how if people use Ranson criteria in Sudan or not. لكن هنا people pretty much almost they stopped using Ranson criteria. Is that correct, Akram?
مظبوط, we moved away from that.
We moved away a long time ago. For multiple reasons, it takes 48 hours to get the full assessment. And if you're waiting 48 hours, maybe you're a little bit too late. That's number one. Number two, the sensitivity and the specificity of Ranson criteria was less than 80%. So it wasn't that good of a scoring system, and it took a little bit of time to get the final score. So we have the clinical-based scoring system, we have the ransom criteria, and we have the Apache 2. Apache 2, you can actually you can Google it, and there's a calculator. It's based on clinical information, patient age and clinical information, and you can just put in the number and the information, and it will give you the score. So what we found is that score greater than 10 or admission will have a sensitivity of 71% and specificity of 91% predicting severe acute pancreatitis. الحاجة الكويسة about the Apache 2, it does allow recalculation and reassessment, and it did significantly better than Ransom at 48 hours. ونحن قلنا Ransom كان less than 80% predicting severity. وانا ممكن اقول لكم I don't use Ransom and I don't use Apache 2. The other scoring system is organ failure, and Ransom Apache are clinical, and Marshall SOFA are organ failure scoring system. They will look at the function of the organ, and they will try to predict which patient is going to have severe course. People think that the SOFA is a little bit easier to use, and it's comparable to Marshall and comparable to Apache 2 in predicting in-hospital mortality and severity of pancreatitis. A SOFA system, again, it's an organ failure. A lot of the number in the SOFA system actually come from an ABG, PO2, gas exchange. That will determine the SOFA in addition to multiple things. There are bilirubin and multiple things. Again, all these score systems are available online. You can just Google them, and immediately will take you to a site where you can calculate. You just enter the data, and it will give you the score. أي زول في السودان عنده خبرة مع ال organ failure scoring system or a clinical scoring system؟
نرحب ببروفيسور سليمان حسين.
يا مرحبا بروفيسور سليمان، أستاذي شخصيا.
يا هلا بروفيسور سليمان، سليمان حسين، مرحبا بك، شرفتك. I think محمد علي رافع يده، عندك سؤال لكن برضه ممكن نسمع منه.
ما سؤال بس قبل شويه، معلش ما قدرت اقول. بالنسبه للسودان هنا، طبعا احنا في السودان عندنا مشكله انه اللاك اوف، يعني زي ما بيقولوا لوكال بروتوكولز تو مانج الديزيزز دي وكده. لكن طبعا في حاجات بتحكمنا، مثلا ليميت ريسورسز. انا طبعا ريسيرش سيرجري، جنرال سيرجري وكده، ليميتد ريسورسز. البيشنت بيجيك في حاجات كثيره بتحكمك، اذر فاكتورز. البيشنت ما بيقدر يعمل كل الانفستيجيشنز، ما كل الحاجات، فبنكون تارجتد يعني في المستشفى. يعني we predict almost severity of the disease من حاجات معينه. بنشوف اذا البيشنت مثلا عنده organ failure، الاي بي جي بتاعه مثلا والله البيشنت ده severely acidotic needs ICU admission وكده، فبنمشي بالطريق ده. لانك انت ما كل الحاجات مثلا بتكون في المستشفى متوفره، ما كل الانفستيجيشنز، ما كل الريسورسز فيه، ما في جهه تقدر تكفل كل الحاجات للبيشنت وكده. فيا حبذا لو كان في local protocol مثلا at least مثلا to pick 1 2 3 this patient is going to have this، ومثلا البيشنت كان عنده كده وكده ممكن يكون ده mild disease وكده. شكرا.
يديك العافيه يا محمد، مشكور. كلامك
ويلكم بروفيسور سليمان.
تفضل.
السلام عليكم محمد. Again, very pleased. I'm very pleased to see you and to listen to this valuable lecture. ما مستغرب عنك يعني. From long time ago, I predict that you will be sometimes teaching us what to do. Unfortunately, it depends on where you are. I had a very good experience with the ransom criteria for a very long time. And at that time, it was working. And of course, even internationally, it was only at that time. But nowadays, with the more, we are moving towards, there is the involvement of more critical care departments in different hospitals. But unfortunately, not on all the hospitals. عشان كده you are moving to the Apache score more than the ransom criteria. You rightly said the ransom criteria, you have
شكرا فقدنا بروفيسور سامح حسين.
أنا أفتكر يا حسام ممكن آخذ فرصة. في زول خاشة. الموست I'm personally لارانسون لأباتشي زي ما قلت أباتشي a little bit يعني more هي صح you can google it لكن المور useful أكتر حتى للمانجمنت أنا I think the Marshall score ولا الموديفايد مارشال لأنها يعني most more easier يعني ممكن تقول صح سوف لكن يعني serum creatinine ABG systolic blood pressure يعني المارشال هي you can use it حتى even مش بس في الكلاسيفيكيشن لكن it can guide the management بتاعتك. افتكر كده ما اعرف رايك شنو انت فهي just it's a part of routine بتعملها مع الكلينيكال كونديشنز كلها. بعد كده it can guide you يعني مثلا العيان he need acute kidney injury that need dialysis كده you need ICU admission and so forth. Thank you.
شكرا جزيلا. بتفق معاكم تماما. يعني I'm biased a little bit لانه احنا tertiary center فاغلبيه العيان اللي بيجونا بيكونوا they're transferred from other hospital already بيكونوا intubated or organ failure يعني بيجوا straight to the ICU. In my practice I rarely use an organ failure scoring system of SOFA Marshall Apache. I rarely use them. What I use SIRS. إذا البيشنت عنده SIRS I use a single parameter scoring system. يعني on presentation I order C-reactive protein and procalcitonin. أنا متأكد إنه ال CRP متوفر في السودان ما متأكد لو ال procalcitonin متوفر ولا لا. يعني I like those لأنه C-reactive protein is really good and accurate differentiating mild from severe acute pancreatitis. لو C-reactive protein 150 reach the 150 within 48 hours. This is 70 to 80% differentiating mild from severe. After 48 hours, low, if it's more than 200, it accurately predict worse outcome. To me, it's the parameter of choice differentiating necrotizing from interstitial pancreatitis. يعني حتى أنا لو ما عندي CT scan available, I will use a C-reactive protein to tell me, okay, the CRP was 150 on presentation, or now it's more than 200 after 48 hours. This patient likely has necrotizing pancreatitis. And I will start treating it this way, and I will treat them as severe pancreatitis. Procalcitonin, I use it to predict infection. So if the procalcitonin, you can order it on presentation, 2 days later, 5 days later, a week, whatever, whenever you want to use it, it predicts infection. So if the procalcitonin is 1.8 in the first few days, this is 90% sensitive and specific, predicting necrosis and infected necrosis, I should say, and organ failure. So I personally use just a simple SIRS and single parameter scoring system. This is what I use in my practice when patient hit our emergency department. أي إضافة من الشباب؟
طيب يا يلا لكن when you use a single parameter ما حتغنيك من ال CT scan. At the end of the day انت you have لو في في necrosis ولا في necrosis ولا حتى infected necrosis you need radiology CT classification ولا evaluation, isn't it? يعني في النهاية
That is correct. That is correct. لكن السؤال بيبقى عن التايمينج. يعني
التايمينج yes.
بالضبط كده. يعني necrosis you see necrosis on CT scan usually after 48 hours. Usually even patient who presents with pancreatitis, when you do the CT, if you do the CT scan when they hit the emergency department, you're not going to see necrosis. Infected necrosis usually happen 3-4 weeks down the road. You're not going to see it early on. An aim of an assessment of severity, the main function of assessing severity is for you to say العيان ده حيمشي العنبر والعيان ده حيمشي الICU. This one we're gonna keep here. This one is gonna go to a bigger hospital and tertiary hospital عندهم ICU. This is a CT scan does not answer that. لأنه usually these patients you need to make that assessment in the first 48 hours. لو قعدوا معاك أكتر يعني once they إنه يقعدوا معاك 4 5 6 يوم and they're not improving, you pretty much have your answer. لكن انت ما دارس يكون قاعد في مستشفى صغيره او ما عندك ICU and all of a sudden they crash or they go into renal failure. You're trying to prevent an early hospital mortality. A CT scan can predict severity, but people rarely use it, and we're going to talk about it here in a second. I've never used CT scan to predict severity. Again, the function of assessing severity is on presentation the first 48 hours to allocate the patient. To see necrosis in CT scan, you see it after 48 hours. To see infected necrosis, that happens down the road. You rarely see infected necrosis in the first few weeks of presentation. Does that make sense?
يا اي صح. alright نمشي لقدام لأن أنا يعني that's why لما that's why I said إنه في المارشال ولا الموديفايد مارشال لو جيت الهاي كرياتينين إنه في organ failure دي it can dictate حتى what you can say early intervention اللي أنت دايره للorgan failure أو يعني if I have a high creatinine في عيان أو systolic blood pressure زي في الموديفايد مارشال that definitely is for ICU. لكن ما أعرف أنت لو لقيت مثلا لو لقيت CRP more than 200 طوال العيان ده you're going to hit him to the ICU.
This is a very good question. I do not. لأنه it truly depends on where you practice. يعني أنا بالنسبة لي حتى لو العيان دخل الفلور it's الفرق بين السيرجيكال فلور والICU طابق واحد. It's one elevator. يعني one phone call 5 minutes البيشنت هيكون في الICU. And I have a 24-hour 24/7 ICU coverage. يعني الإجابة ل what I practice here غالبا ما حتكون الإجابة الصح for how you do things in Sudan. وده ذاته سبب الدiscussion ده so we can figure what is the right way of doing things. لأنه يعني if you read the book and the papers, there's no scoring system that's superior to the other. Absolutely no. Ranson, Marshall, C-reactive protein, creatinine alone, hematocrit, all of them have been studied. ما في واحد is superior to the other. It's using what you think is appropriate for you. وأنا بعتقد إنه في السودان you want to predict the severity a little bit earlier لأنه logistic support may be a little bit different and it may take time to mobilize the patient. يعني بالنسبة لي هنا mobilizing the patient from the floor to the ICU, that's a 5 minutes. Done. But even if we miss it, it's not a big deal because we can act quickly. We can even intubate the patient on the floor if something happened and send him to the ICU. Patient going to kidney failure, within 10 minutes you will have a dialysis access and we can start dialysis in the middle of the night. فعشان كده بستعمل السيرس يعني a C-reactive protein for me alone. I don't use that. I don't use the procalcitonin alone. That's why I قلت بستعمل السيرس, the heart rate, the blood pressure, the respiratory rate, the temperature. I use the SIRS in addition to a single parameter scoring system. This is what I use to allocate the patient in my hospital. Lakin I use that based on the logistic support I have here. That may not be appropriate في Sudan لأن logistic support could be different.
Yeah, that makes sense. Thank you.
يا حسام في برضو مستر تامر كان رافع يده قبل ما أعرف كان عنده لسه تعليق أو مداخلة ولا؟
اتفضل مستر تامر.
السلام عليكم. معلش just I lost the network connection for a while, but anyway, actually when I was speaking about the experience here in Saudi Arabia, I'm working in one of the highest tertiary centers actually in Jeddah. Mainly we are using the multifactorial severity scoring systems. Definitely the outcomes comes from actually the Ranson criteria or even the biliary modification of the Ranson criteria. As mentioned by Dr. Osman, it's having unfortunately a little bit lower specificity. Emery from the England, Apache 2, which is the most reliable actually in my center. Modified Marshall is nice, but we are using most of the time currently, as mentioned by Dr. Osman, the single test severity scoring, which is mainly based on the C-reactive protein, and on some occasions actually using even the interleukin 6. Thank you, Dr. Osman.
مشكور مستر تامر. فما اظن انه احنا حنصل الليله لانه what is the best thing to do in Sudan. اظن حنصل الليله انه المجموعه اللي قاعده حاليا في السودان انه like you guys are going to get together after this and you're going to figure out which one is going to work in Sudan. If we just initiate the conversation that this is something that we need to do, we need to identify which patient is going to get sick and mobilize them so they don't die early on in the hospital, we accomplish our goal today. لكن لو سألت أي زول في كل العالم أي زول حيديك إجابة مختلفة عن which scoring system, which system they use to assess severity. For example, radiological scoring system, I've never used it. I don't know anyone who uses that actually in the United States, including the modified severity index that talk about the degree of necrosis, no necrosis, 30%, more than 30%, enlargement of the gland, presence of fluid collection. I think they use it in Europe, but I'm not aware of any center in the United States that uses this. Again, it depends on where you are and its radiological scoring system. To adopt this, you must have a CT scan available to do that readily. So again, it depends on the logistics support. It depends on the risk, what I call risk aversion. Meaning that انت لو عندك عيان how much risk are you willing and can you take. اللي هو دي الحاجة اللي أنا قلتها. إذا أنا if I made a mistake here أنا خطيت العيان في الفلور I can handle that risk لأنه في العيان if I'm wrong and العيان deteriorated I will know right away and I can correct that mistake. لكن في نفسي هنا في أمريكا عندنا في تكساس is البراكتس في تكساس يعني ممكن يكون قريب شوية للسودان لأنه there's a lot of small town in Texas that they don't, sometimes they have only 1 or 2 ICU bed. So their job is to identify which patient is going to get sick and send them to us right away because they cannot afford to take that risk, if that makes sense. For all it depends on if you have the scoring system and the requirement for the scoring system available, whether it's clinical, ABG, certain blood work, whether it's radiology, and how can you integrate that in your support. We're going to try to move a little bit quick لأن لاحظت إنه يعني الدسكشن لطيف وأخذنا زمن. فنبدأ في المانجمنت. نحن لسه بنتكلم في phase 1 بنتكلم في first few weeks of pancreatitis. The most important intervention in phase 1 is fluid resuscitation. It is the intervention most likely to improve the outcome. There's no high-level evidence that will tell you which fluid to use, what is the rate, and there's no data. There are data that will tell you crystalloid and LR with normal saline are equivalent to colloid. I can tell you in our practice in Dallas, we use crystalloid, we use lactated ringer. We use lactated ringer because we believe lactated ringer will lessen the SIRS response. And we believe resuscitation, or we know that resuscitation with a high volume of normal saline will cause metabolic acidosis, and it can ruin some of our parameters that we look at. Okay. And because there's no clear guideline to tell us how to measure or how to calculate the fluid that we give to that patient, we monitor the response. We want their heart rate. If they came in tachycardic, we resuscitate them with fluid until their heart rate drops. If they're hypotensive, we want to see their blood pressure go up. We put a Foley catheter to make sure that their urine output improves. So we monitor our response to fluid resuscitation, and fluid resuscitation is important in the first 24 to 48 hours, meaning that 3 days into the pancreatitis, fluid resuscitation after 2-3 days is really not that significant as it is in the first 48 hours of presentation. And our fluid of choice is lactated ringer. Okay. الحاجة الثانية when they come in sick, and this is really for a patient who end up in the ICU, is their need for vasopressors. You give them a lot of fluid, you believe that you resuscitated the patient well, lakin they still hypotensive. They have significant systemic inflammatory response syndrome and they're hypotensive, then they need pressor. Our pressor of choice is levofed, norepinephrine, and vasopressin. لو عندهم acute kidney injury and they're acidotic, and or they go into significant pulmonary hypertension, we use CVHD, continuous venovenous hemodialysis. It's more gentle than conventional hemodialysis, and the patient can tolerate that while being on pressors. Meaning that a common mistake that we see here when patients get transferred from other hospital is that the patient do not get adequately resuscitated because treating physicians are afraid of pulmonary edema. Treating physicians are afraid of congestive heart failure or overloading the patient. And again, that depends on your logistic support. To us, that's not a factor. If a patient with severe pancreatitis hit my ICU or my emergency department, we're gonna flood him with fluid. Because if he develops pulmonary edema, he's gonna get intubated. They don't die from pulmonary edema, they die if you don't adequately resuscitate them from acidosis. If they are in renal failure, they're gonna end up intubated. We don't care, we get them intubated, we start CVHD, because they're not gonna die from renal failure, they are gonna die from being under resuscitated. So again, this is depend on our logistic support. ونسمع من الشباب في السودان لو في زول عنده خبرة عن managing patient pancreatitis who present with significant hypertension despite adequate resuscitation, or patients who go into severe dialysis while being hypertensive.
الفرص مفتوحة طبعا، وبرضه يا ريت نسمع من بروف سليمان ومستر علاء ومستر تامر وكل المشاركين. أنا ما عرفت يعني لو عندنا سينيورز موجودين برضه، لكن أي زول عنده فرصة اتفضل طوالي أو ممكن ترفع يديكم.
Okay, we'll keep moving. الحاجة الثانية في phase 1, the question is antibiotic. When do we use antibiotic? And again, we are talking about the acute phase. We're talking the first few weeks of pancreatitis. ولو تتذكروا أنا قلت في acute phase or for phase 1, it's very rare that you have infection. Okay, في 7 randomized controlled trial between 1993 and 2009 that had conflicting results. لكن في 3 good trials and 3 good studies, double-blinded studies between 2004 and 2009 that showed no beneficial effect of prophylactic antibiotic. And again, we're talking about prophylactic antibiotic. There's no effect in preventing infection or need for surgery, and that did not affect mortality. Again, we're talking about using antibiotic in the early phase, the first few weeks. Patient present with necrotizing pancreatitis, no infection, they're just sick, they have fever, white count of 20 or 30,000, and they act as if they're in septic shock, but it's not septic shock, it's severe SIRS. Does that make sense, guys? I'll take silence as yes. الحاجة الثانية في phase 1, when do we use ERCP? Okay. قبل ما امشي كده، قبل ما امشي من الانتبيوتيك. We use antibiotic in the early phase if they present with biliary pancreatitis and cholangitis. So early on presentation, I only use antibiotic if they have cholangitis, if they present with biliary pancreatitis and they still have an impacted stone in the bile duct and cholangitis, I would use antibiotic. Okay, or if they have pancreatitis and cholecystitis, I would use antibiotic for cholecystitis. And let me tell you something about cholecystitis. Cholecystitis is the most missed diagnosis in patient with severe pancreatitis. والحاجة اللي بتلاحظوها إنه العيان بيجيك بpancreatitis بيكون قاعد معاك في المستشفى and you get really consumed by the pancreatitis. And then few weeks down the road, they start having fever. You don't know why. Even you do CT scan, you don't see every infection. Always think gallbladder. A lot of these patients will develop cholecystitis, and a lot of time cholecystitis will get missed. But again, in the early phase, I only use antibiotic if they have cholangitis or they have cholecystitis. But I don't use antibiotic for sterile necrosis. ERCP is only recommended if patients have cholangitis. If they have impacted stone, they get ERCP. There are different ways to try to minimize further pancreatic irritation after ERCP, using pancreatic stent, rectal NSAID to decrease post-ERCP pancreatitis. There was an ongoing trial about the role of early ERCP and pancreatic sphincterotomy to see if that will affect the course of pancreatitis. I don't think the outcome of that trial is out yet. I haven't seen it yet. لحد ما اتاكد لو octreotide قاعد في السودان ولا لا، لكن there's a lot of papers that talk about use of high dose octreotide in severe pancreatitis and how using high dose octreotide can actually improve the outcome in these patients. الحاجة الimportant ده اتكلم عنها برضه nutritional management. A meta-analysis revealed that any type of nutrition support, whether it's intral, meaning through the GI system, or parental through TPN. وانا متاكد لو في TPN متوفر في السودان في اي مكان، لكن whatever nutritional support you can give to the patient will improve their outcome. Patients without nutritional support have significantly worse outcome. فكان في 8 randomized controlled trial between 1997 and 2010 comparing TPN, total parenteral nutrition, venous nutrition, versus intral nutrition, like tube feed or just allowing the patient to eat. 3 of them reported significant improvement in the intral group versus the TPN. 3 reported insignificant improved outcome in favor of the intral nutrition, and 2 reported no significant difference. Overall, we believe that total intral nutrition, meaning that feeding the gut, is superior to TPN and more physiological. Okay. So if we decided, okay, we're going to feed this patient through the gut, do we use the gastric route or do we use jejunal tube? The traditional teaching, even here in the United States, is to bypass the pancreas and bypass the stomach and feed the patient directly into the jejunum. We put a post-pyloric tube feed. I can tell you, this is not the practice anymore. Nowadays, we do not care. We want to feed the patient. I rarely use jejunal feed unless the patient cannot tolerate gastric feed, meaning that feeding the patient by oral feed or nasogastric feed does not worsen their pancreatitis. If they cannot tolerate it, that's one thing, but it does not worsen their pancreatitis and it does not affect their outcome. Okay. The other question is, when is the timing? When do you start intral feeding? As soon as they're ready. I personally wait until they are well resuscitated. I don't like to use intral feed or gastrointestinal feed early on if they are on pressors, especially if they're in a high dose pressor, or especially if they're on 2 pressors. Lano pressor will lead to intestinal ischemia, and adding intral feed can actually increase the demand of the intestine and worsen their intestinal ischemia. And intestinal ischemia and colonic ischemia is a serious problem that you can actually see. There was a trial that was published in 2014 that showed no difference between early feeding within 24 hours versus standard what we currently do 72 hours from presentation. والحتة دي I really want to hear من الناس في السودان, how do they manage patient nutrition with severe pancreatitis?
حسام انا افتح الفرصه في الحته دي. برضه في دكتور محمد علي كان رافع يده قبل شويه، وقبيل كان في زول اسمه ظاهر ايفون، ما عرفت الاسم منه، برضه كان طالب فرصه قبيل. تفضلوا طبعا.
معلش يا مستر.
السلام
محمد علي
عليكم.
انا.
تفضل يا محمد.
لا خلاص، خلي الدكتوره تخش بعدك.
شكرا يا محمد علي. أنا ريم بليلة، Associate Professor of Surgery University الخرطوم. currently أنا شغالة في المملكة العربية السعودية في الجنوب، منطقة الجنوب. أول حاجة برحب بكم وبرحب ببروفيسور سليمان حسين، وشكرا لك يا حسام ويا دكتور أكرم for this very nice presentation. صراحة أنا كنت رفعت قبل لأني كنت كونسيرن إني أتكلم شوية عن الحتة بتاعت الكلاسيفيكيشن سيستمز للسيفيريتي اوف بانكرياتايتس. افتكر الموضوع هو ماشي شوية، لكن بس أنا would like to say إنه يعني whenever الميديسين كله تلقى لك a lot of classifications معناها none of them is working perfectly.
True.
ودي الحاجه الواضحه في الكلاسيفيكيشن بتاع الاكيوت بانكرياتايتس والسيفيريتي بتاعته. فزي ما انت قلت ان هي محتاجين لها للبريدكشن اوف سيفيريتي، لانه when the severity develops ما حتكون مست باي واحد من الكلاسيفيكيشنز، لكن البريدكتيفيتي بتاعتها is low. دي الحاجه الواضحه في كل، يعني يمكن نقول بدون اي كونسرفيشن في معظم الكلاسيفيكيشنز. كنت دايره برضو اخليك تتكلم شويه عن في الحته بتاعت السيفير بانكرياتايتس early intervention versus delayed intervention. فبس انت لما ان شاء الله نتواصل في كلامك لا تسنو.
وجايين حته الايرلي versus delayed intervention جايين.
بس خلاص شكرا لك، شكرا جزيلا. ثانك يو فيري ماتش. الله يسلمك.
دكتور حسام معلش
تفضل.
في حته الانتي بايوتكس انا I have two questions.
تفضل.
طبعا انا زول جونيور وانت زول هيباتوبيلاري سيرجن وكده، فانا بس يعني ليه وللاذر ريسيرش وي نيد يعني البوينتس تكون كلير فور اس. اتكلمت عن الانتي بايوتكس انه نو نيد فور انتي بايوتكس، وفي فيز 1 يعني most probably there will be no infection. البيشنت ما بيكون infected even لو كان السي اكتيف بروتين بتاعه very high وانت قلت you use it as a parameter. وانه حتى التوتال اذا كان هاي مثلا بتقول والله يا اخي this is مثلا systemic inflammatory response syndrome وكده. طيب for junior stuff how to differentiate انه this is والله truly this is infection.
اوكي
خلاص، ولا انه this is والله systemic inflammatory response، لانه التوتال هاي السي اكتيف بروتين is high، patient بيجي بكل السيمبتومز، ممكن يكون فيبرايل وكده، وبعدين الفيز دي ممكن الامريكان بيبل يكونوا مثلا accurate في giving history وكده، لكن هنا بيجونا يعني a lot of patients هو الفور ويكس فيرس 4 6 ويكس دي ما بيقولها، بيقول لك والله يا اخي طولت دي شهر شهرين ثلاثه على حسب احساسه اللي هو بيقول لك. دي الحاجه الاولى. الحاجه الثانيه، هل في حاله زي دي الكونفirmation بيجي بالسي تي؟ يعني better to do CT abdomen مثلا ولا اي imaging modality انه يا اخي والله to identify انه والله this is could be a serious infection، وانه الموضوع ده ممكن يكون مثلا miss history، البيشنت ما ادانا history كويس. المهم و if we use antibiotics what type of antibiotics is specific for pancreatic.
تمام. اديك راح حمد. الحاجات دي كلها جاينا، لكن خليني ارجع لموضوع الانتيبيوتيك وموضوع البارامتر. لما قلنا السي رياكتيف بروتين، البروكالسيتونين، الكلينيكال سكورينج سيستم and so and all of them, they do not diagnose an infection, they predict an infection. ففي difference. يعني هذا لما تقرا عن whatever scoring system or whatever lab work or whatever we do, either we try to make the diagnosis or we try to predict what's going to happen. A C-reactive protein, if it's high on presentation, that does not diagnose infection. That predicts infection and severity in the future. Does that make sense يا محمد؟
ايوه.
يعني معناها
معلش انا قصدي مش السي رياكتيف بروتين الون، انا اي نو، لكن قصدي سي رياكتيف بروتين الون، يعني سي رياكتيف بروتين از هاي بلس كل الفيتشرز بتاعت السيستميك انفلاماتوري ريسبونس سندروم، وحتى ايفن التوتال اذا كان هاي. انا هاو تو يعني تو ديفرنشيت انه والله ذيس از ترولي انفكشن بالكومبينيشن بتاعت الحاجات دي، ولا انه الموضوع ده والله از جاست سيرش.
اوكي تمام. ونحن حنجي هسه اللي قدام في البرزنتيشن حنتكلم كيف انه احنا we make the diagnosis of infected pancreatic necrosis. لكن as I said early on in the first phase, the first 1 to 3 weeks, it is very rare to have infected pancreatic necrosis. A lot of time it's just SIRS reaction. If you are really concerned about infection, then you can start antibiotic. The problem of starting antibiotic too early that you can build resistance, and resistant within that patient or community resistant. هيكون في overuse of antibiotic. لكن اللي قدام هنتكلم how to make that diagnosis، لأنه that diagnosis of infected pancreatic necrosis should come to your mind once you're approaching the end of phase 1, or if you're early in phase 1 but the patient is just not responding to what you do. يعني practically أنا هسه قلت إنه I do not use antibiotic in the first 2 weeks of severe pancreatitis unless there's a cholangitis or unless there's cholecystitis. I would sometimes use it if the patient is just very sick and they are not responding to what I do. I would then start antibiotic زي ما انت قلت ما لانه I think انه انا عندي infected necrosis for the fear of missing other diagnosis. ولو ذكرت انا قبل قلت انه الترند في امريكا حاليا is not to use CT scan for to diagnose pancreatitis. لكن تتذكر قلت لسه احنا في Dallas our practice is to use CT scan a little bit more than other area in any patient above the age of 40 and to rule out other diagnoses. Does that make sense, Muhammad, to some degree? But we're going to come to talk about how to make the diagnosis of infected necrosis once, because right now we're talking about phase 1. We're going to move toward phase 2.
شكرا يا مستر. يعني that's answer my question. الفلكسبيليتي في الميديسن دي حاجه كويسه، الريجيد حاجات دي. Thank you.
Exactly. But ما في حاجه هنا black and white. There's no black and white in pancreatitis. في phase 1 حتى نتكلم عن acute fluid collection. If one of the important point that I want to stress إنه avoid local intervention early on. لو عندك عيان ب severe pancreatitis وعيان ال first 2 or 3 weeks وعملت له CT scan and there's necrosis and there's acute necrotic collection والعيان is sick, try not to operate on the patient. لأنه likely they are sick because of their SIRS. And taking them to surgery is not going to make them better. That's number 1. Number 2, their necrosis is not well defined yet. معناه لما تسوق من OR, you're not going to know what to debris, what not to leave alone when it comes to pancreatic debridement and necrosectomy. And there's a very high risk of bleeding, and we're likely going to need to take these patients to the OR again. So, and again, in phase 1, the first 3 weeks, let's just call the first week of severe pancreatitis, try not to intervene locally as much as you can. As long as there's no infection, and it's very rare that there's infection. Try not to operate on these patients. So when to intervene early? الحاجة بقول لك إنه when I have patient with very severe pancreatitis and they act really sick, and they're not improving in the first week or 2, and I do a CT scan and I see a lot of fluid, a lot of acute necrotic collection around the pancreas early on, sometimes that happens rarely. Sometimes I put a percutaneous drain early on, meaning IR placed drain, and we believe by draining the collection around the pancreas, we get rid of the cytokines and we decrease their SIRS. So we do not intervene for infection. This is an percutaneous intervention to get rid of the cytokines. But we do our best not to intervene and not to operate in the first phase. الحاجة الثانية اللي you can encounter it early on الabdominal compartment syndrome. يعني again دي برضه حاجة flexible depending on the timing. الحاجة الدائرة نتكلم عنها a rule of decompressive laparotomy. يجيك عيان ب severe pancreatitis, and here we're talking about the first 72 hours of presentation. بيجيك عيان ب severe pancreatitis and you flood them with fluid and they end up intubated with renal failure and their abdominal, their bladder pressure is high, above 20, with kidney failure and yada, yada, yada. When do you consider decompressive laparotomy? I can tell you that I try to avoid decompressive laparotomy as much as I can. My senior partner, he still does decompressive laparotomy very rarely. I pretty much stopped. لأنه when they reach that a status in the first 72 hours from presentation, this is not the abdominal compartment syndrome that is talking, that's the SIRS that is talking. Meaning that regardless of what you do, they are going to die. فلما يكون عندي عيان abdominal compartment syndrome with severe pancreatitis, I treat them medically. Usually now we're 72 from presentation, so I'm done with my fluid resuscitation. So العيان that I use dialysis, CVHD, we pull fluid, diuretics, vent management, I paralyze them, and try to manage that medically as much as I can and try to avoid decompressive laparotomy. لما نمشي على phase 2 بعد ذاك حنتكلم when to intervene، واظن دي الحته اللي كان الدكتور ريم ده نتكلم عنها، انه early on do not intervene But when we come to phase 2, when we start talking about phase 2, we're going to talk about when to intervene. وحرجع عليك تاني يا دكتور ريم لتعليقك لما نصل الحتة دي. The other thing that I want to talk about in phase 1, sometimes is phase 2, is hemorrhage. Okay, when you hear hemorrhagic pancreatitis, or specifically we're talking about a pseudoaneurysm of the gastroduodenal artery or the splenic artery, and these patients will just crash on you. Their blood pressure will just plummet, and their abdomen will get distended. We make the diagnosis by a stat CTA. We see a pseudoaneurysm, or sometimes we see an active blush and extravagant contrast. But any abnormal, if they're acting like bleeding or hemorrhagic pancreatitis and they're hemodynamically unstable, I don't need to see an extra. If I see a pseudoaneurysm or a funny looking vessel, we go for IR angioembolization or stent placement. This is a life-saving procedure, because taking these patients to the OR, they rarely survive. Actually, I've never seen anyone who got operated on for hemorrhagic and bleeding pancreatitis who survived operative intervention. وبرضه ده اسمع حاسس من الناس السودان في حته availability of interventional radiology لانه حنكون محتاجين لها شديد في phase 2. Any takers?
طيب انا ريم حرجع لكم ثاني. To be honest لما كنت هناك في السودان ما كان it is very difficult to find an interventional radiologist to do that. Anyway, right now أفتكر في دكتور مصطفى النور, he had finished his rota أو his training في interventional radiology في Malaysia, and he's supposed to come back. So hopefully he will be able to handle that.
Okay. So we're going to keep moving. الحاجة الثانية في phase 1, sometimes في phase 2 that we can see is pancreatoenteric fistula. You see a fistula between the colon, duodenum, or the pancreas. And you should suspect that when you do a CT scan and you see a lot of gas in the pancreatic bed, a little bit more than you'd expect, and the patient is not that sick. When you see a lot of gas in the pancreatic bed and the patient, again, is not that sick, you should suspect a fistula between the GI system and the pancreas. A lot of the time, you can treat those patients non-surgically. If they have collection, you need to drain that collection, usually drain percutaneously through IR. If they're septic, you put them on antibiotic. We rarely need to operate on these patients, okay? Moving to phase 2. When they approach phase 2, these patients, they are either have resolved organ failure or improving organ failure. These patients, we continue with supportive care, and then we intervene if they develop symptomatic wall of pancreatic necrosis. And that's the delayed phase, and we said we're not going to talk about phase 3, we're going to focus on phase 2. But if they are improving, they don't have evidence of infection, we'll continue the supportive care and intervention if they develop symptoms. It's not based on size. It's not the 6 centimeter or 7 centimeter, whatever the size of the fluid collection. Later on, it's dependent on symptom. The other thing, the patient can continue to be critically ill, and ديل العيانين حابين نتكلم عنه, because we have to define, do they have infected necrosis at this time, اللي هو ده كان الكويشن بتاع دكتور محمد علي. So how do you make the diagnosis of infected necrosis? We make the diagnosis of infected necrosis on CT scan if they have gas in the fluid collection on a CT. We do a CT scan and we see air in the pancreas and the patient is acting sick, they have infected necrosis. The other thing is a positive culture of pancreatic or parapancreatic necrotic tissue. And the biopsy or the specimen can be obtained either through interventional radiology or through endoscopic ultrasound. The reason I have this here to tell you, never do it. Do not do that. Do not biopsy pancreatic necrosis to determine if the patient is infected or not. You will read it in the book. Do not use it. Use one of the two. Either you have a CT scan with gas in the pancreas, or you suspect the patient has infection because the patient has persistent sepsis and he is not progressing well despite your maximal support. Okay. وأي عيان يجيك إنه في زول كان عمل له biopsy, even if he was not infected at the time, he's infected now. يعني لو أنت عندك CT scan that shows gas in the pancreas, this patient has infected pancreatic necrosis, treat him that way. لو جاك عيان محول من حتة ثانية وفي زول عمل له biopsy or sampling of the pancreatic tissue, assume this patient now has infected necrosis, even if he did not have that before the sample. Or if you do a CT scan and there's no evidence of gas, like the patient is acting sick and is not improving, this patient has infected necrosis, even if you don't see it on CT scan. الحاجة الثانية المفروض تتذكرها إنه with severe pancreatitis, especially in phase 2, yes, you can have the pancreatic infection, but you can also have an extra pancreatic infection. You think about pneumonia, اللي هو العيان عنده central line, think about UTI, think about cholecystitis, think about the things that we mentioned. Okay. The reason I said do not do an FNA, either percutaneous or endoscopic, because there's a 25% false negative rate. Because these patients have worse outcome when we use FNA to diagnose infected necrosis. And actually, these patients have the worst outcome and the highest rate of mortality. The secondary infection from pancreatic necrosis manipulation has the highest risk of mortality. الحاجة الثانية, it depends on the availability of your interventional radiology. يعني, why do I do a percutaneous sampling to determine if there's an infection if I'm concerned? If you're going to put a needle, put a drain in it. Okay, but again, that depends on the logistics support and if you have IR or not. But again, I think in Sudan, I should say, do not biopsy the pancreas or obtain a tissue sample to determine infection. Either you see infection or CT scan, or you clinically suspect that once you approach phase 2. And now we're talking about phase 2. Okay, choice of antibiotic. Choice of antibiotic, the كان برضه سؤال محمد علي. We like something that penetrates the pancreas, carbapenem, which is meropenem that we use here. Zosyn, الايكويفالنت بتاع الزوسن شنو في السودان يا اكرم؟ او واحد من الشباب.
ده نفس السؤال. Piperacillin tazobactam.
اي واحد من الشباب؟ third generation cephalosporin او حاجه زي كده. But generally speaking, carbapenem is our preferred drug of choice because it does penetrate the pancreas. Okay. If the patient is not responding, always think about adding antifungal. Okay. And that's true to any upper or foregut infection. Okay. Now we come to intervention. Now we are in phase 2. Okay. And now the patient has infected necrosis. Now we intervene. Remember I said in phase 1, try not to intervene. Leave the collection alone. The patient does not have infection. It's the first 3 weeks or so. Leave them alone. This is when you intervene. Now you waited 4 weeks, 5 weeks, and now you have infection. For the sake of this lecture, let's just say if you see infected necrosis, you must intervene. It's not an accurate statement, but let's just put it this way. Okay. So the first option of intervention, which my go-to option, is percutaneous drainage. Either CT or ultrasound guided drainage. When you drain and the infected pancreatic necrosis, you have to commit to that because the drain will need to be upsized, will need to be exchanged. You have to ask your nurse and staff to flush them because they're going to get clogged and obstructed a lot with the necrotic material. And if you see here, this patient that I currently have in the hospital, this is a chest tube in his pancreas. That we put a drain, we upsize until we ended up with the chest tube. Okay. The other option is surgical necrosectomy. Take them to the OR for pancreatic debridement. What is the indication? The indication, if they have infected necrosis, you should do something. Okay. If you already drained them percutaneously, when do you say, I have failed that percutaneous drainage and I need to do something? If they have a progressive organ failure, despite adequate drainage, you didn't drainage, you look at the CT scan, you're happy with your drainage, but the patient is not getting better. You have to take them to surgery. Or inadequate drainage. You put a drain and the collection just does not improve because likely you have more necrotic material than fluid. And I love to use MRI for that. MRI is a really good study delineating which is fluid, which is solid. CT scan is not good at delineating solid versus fluid. If you do an MRI and you see more than 50% necrotic material, okay, and less than 50% fluid, which is going to be bright on a T2 weighted image, MRI weighted images, that patient will likely not going to be adequately managed with the drain. You still start with a percutaneous drain, but in your mind, you have to know that this patient will likely need some form of surgical necrosectomy. Or if you have a concern of other missed pathology, meaning bowel ischemia or bowel perforation, that you think, okay, you treated this patient well, but the patient, again, is just getting worse, you will need to take him to surgery. And now we are in phase 2, which now we're talking about after 4 weeks from presentation. You can do this necrosectomy open or laparoscopic. I'm going to talk briefly about the open approach. Usually you do it through an open midline. My preferred approach to get to the pancreatic bed is either you go through the lesser sac, you find a window between through the gastrocolic ligament between the stomach and the colon, and you get to the pancreatic bed, or you go through the transverse mesocolon. And again, that depends on the shape and the location of the fluid collection. That will determine how you approach it. Do your best not to take down the splenic flexure, because there are a lot of times there's a lot of venous thrombosis and venous congestion, and taking down the splenic flexure, a lot of times you can end up with colonic ischemia post-operatively. So do your best not to take down the splenic flexure to get to the pancreas. Either go through the gastrocolic ligament, through the lesser sac, or through the transverse mesocolon. And in this case, usually everything just matted and looks nasty. Sometimes I like to use ultrasound to determine the location of the fluid to access that. A lot of time you have just to use your finger. You feel it and you puncture. You have to be brave when dealing with these cases. Be careful, especially on your way to the pancreatic bed. And when you do a necrosectomy, be careful, because you don't want to injure the colon, you don't want to injure the stomach, and most importantly, you do not want to injure the duodenum. Even if you injure the duodenum, there's nothing to do but to put a drain. When you get to the pancreatic necrotic area, it's a gentle debridement. Okay, it's a gentle debridement. You only take the tissue that is coming easily, meaning don't force it. So usually what I like to do, I like to use irrigation, irrigate the pancreatic bed. The necrotic material will loosen up a little bit. It will make it easier for me to dissect it with a blunt finger dissection, or sometimes I use ring forceps to gently take the necrotic material out. Okay. Again, there's different way of doing open surgical necrosectomy. This is the one that I just talked about, is open necrosectomy, and then I put drains. I put large drains, minimum of 2 drains in the area, and I close the abdomen. Traditionally, people did open necrosectomy with open packing. You leave the abdomen open and you pack the pancreatic bed all the way to the skin. And then in the ICU, you can just change the packing every day. I'm not sure if anyone does that, not here in the United States at least. And there's the open necrosectomy or continuous closed lavage, which you do what I talked about, but when you put drain, use one drain for irrigation, you run saline through one drain and you drain it through the other drain. And it's kind of continuous irrigation for 72 after surgery. And then there's the option of programmed open necrosectomy. So you say, I'm gonna take them to surgery multiple times. But if you wait for the right time, if you wait for phase 2 at the right time, you will not need to do a programmed necrosectomy. It can be, for the most part, one and done surgical intervention. And if you need anything else, you likely can address that percutaneously. Okay. The other approach is the step-up approach that I really like, which putting an IR drain in the retroperitoneal route. They go between the spleen and the colon. You upsize that drain until you get to size 20 French or so. And that if the patient needs intervention, then you can just go laparoscopically or a video-assisted procedure through the flank, use the track that you have from the drain, and pull the pancreatic tissue out, okay? And you should consider that if there's a lack of 75% decrease in the size after 1 week. As I said, MRI, I use MRI a lot. Or if there's multiple organism, when you put the drain and you send it for culture, there's multiple organism, you should think that my percutaneous approach may not work. I love that approach. You see this patient here, we end up placing a chest tube between the spleen and the colon, was going through that area. So I end up using this track to put an operating scope, and usually I put another port here, and we end up pulling the entire pancreas through a small opening here, we put another drain, and this is the only incision the patient ended up with, and that's it. Okay. This is a study that I like a lot that talk about this type of approach. We're not going to go over it. You guys can review it. لكن هنا let me just see. Before I go to the endoscopic drainage, لأنه زي تكلمنا الحتة المهمة, I want to go back to Mr. Reem. لو عندك أي تعليق لهذه الحتة اللي أنت كنت سألت منها.
Thank you. أفتكر إنك قلت فيها كلام كويس. بس let's suppose إنه في patient when he developed some sort of pancreatic infected pancreatic necrosis with more than 50% of the pancreas, which is necrosed. And then this was diagnosed like at the fourth or let us say the fifth week. Do we need to intervene just immediately or delayed after like 6 weeks or something like that? This was something which I faced with one of my patients, and then actually the patient was following with another doctor, and then he delayed her a lot until more than 6 weeks. And then afterwards we have to deal with like, it was already in like phase 3 of the process. So in my opinion, despite that, I know there's a delayed approach, or sometimes they are talking about an improved outcomes, the delayed approach rather than the early approach. For this particular patient, I was thinking about the early approach, which would have been better for her. What do you think?
العيان كان عنده infected necrosis ولا كان just presence ولا sterile necrosis?
No, it is an infected necrosis.
Okay. لا but تبع في infected necrosis زي ما قلت for the sake of this lecture, infected necrosis you have to intervene.
Yes, immediately.
إنه بقول for the sake of this lecture لأنه there's multiple reports now they talk about you can manage infected necrosis, kind of a mild form of infected necrosis, antibiotic alone and wait. There's report that talk about that.
Yes.
In my mind, I'm not sure this patient have infected necrosis. I really think this patient, a big number of them, they have a they have an intestinal fissure to the pancreas. You see gas on the CT scan, you diagnose them with infected necrosis, but they're doing great and either treated with antibiotics. I'm not even sure they truly have infected necrosis.
So you are questioning that even those who respond to the delayed approach with in conservative management you are not sure if they have really infected necrosis.
I think if the patient has infected necrosis, I think that the patient will let you know. The patient will force you to do it. And usually this is what ends up happening.
Yes.
We try to delay, and then the patient will let you know. The patient just not responding.
Yes.
You do something, the white count will drop, but then fever tomorrow. White count up the day after. The kidneys not getting worse again. The patient will let you know. If you are successful, the patient is getting better without intervention, either radiology or surgical intervention, then the likelihood either this was truly a very mild form of infected necrosis, or more likely was not even infected necrosis and the patient just had a fistula to the GI tract, and that's why you see gas. And the white count and all that were just residual from the surgery action. So it's really judgment call, but for the sake of this lecture, if you have a confirmed infected necrosis, which is presence of gas on CT scan, or you suspect that because the patient is not getting better and you're approaching phase 2 or you are already in phase 2, intervene, do something. The patient is ready. The reason for delay, because in the first phase, it's unlikely for that to be infection. You're operating for SIRS. We should not operate for SIRS. It's because the pancreas is not ready. The dead and necrotic area is not well defined yet. So you're not going to do an adequate necrosectomy. There's a high risk for bleeding, and you're likely going to injure something, and the patient will bleed heavily in the OR. So that's the reason why we delay. Does that clarify things, Mr. Reem?
Yes, thank you very much. Thank you.
Allah khalik. Mashkoor, Mr. Reem. The other thing quickly, I'm going to talk about endoscopic drainage. Really, I don't want to talk about this a lot. It really depends. Do you have GI available? Do they have endoscopic ultrasound availability? Are they committed to that? Because patients who undergo for endoscopic necrosectomy, they require multiple trip to the GI suite, and usually you have to wait more than 6 weeks for them to have a mature collection. It's a mature walled pancreatic collection. And then how acute, if the patient is sick and crashing, you really don't have time to go to the endoscopic suite today and then after 2 days and wait for 6 trips. Because this study will mention that this patient will need a mean of 6 intervention to really adequately do an endoscopic necrosectomy. So something to keep in mind, something that you should know about. Only few centers will use that aggressively because it depends on patient selection and depends on your gastroenterologist. Okay. The other dual modality drainage is something that even here in the United States is known in the Virginia Mason group, which is a group in Seattle. They do a percutaneous drain and an endoscopic drain, and then they flush and irrigate, and I believe that worked. That's the only center who actually managed to have a positive outcome from that approach. All other centers did not really have good results with that. Okay. The other thing that I want to finish with is that timing for a cholecystectomy, especially patients who present with biliary pancreatitis. We know in mild acute pancreatitis, you want to do cholecystectomy, that admission, if possible. In severe pancreatitis, you do not have to. In severe pancreatitis, I would take the gallbladder out if they're going for surgical necrosectomy. Otherwise, I do it in delayed fashion once their pancreas fully declares itself, which is phase 3 or after that. Okay. حاجة تاني quickly before I finish, to help you differentiate between percutaneous approach versus surgical approach versus what to do is the shape and the location of the necrotic tissue. If the necrotic tissue is a necrotic collection is central behind the stomach, then you have all options available to you: IR, endoscopic, and surgical. If the fluid collection is mostly on the left side by the tail of the pancreas sitting by the spleen, then endoscopic is not going to do well with that. My preferred approach would be to put a percutaneous drain and then the VOD, what we talked about, percutaneous drain, upsize, and then go through a video assisted. If the necrotic collection is actually traveling and going to the colic gutter, especially on the right side or both sides, going all the way down to the pelvis, or a huge collection extending all the way down to the central abdomen, this is the patient that, yes, I may start with a percutaneous approach, but I know this patient is going to end up with a surgical necrosectomy. And I think we're going to finish with this. And لو أي واحد فيكم مرة زار أمريكا وجاني هنا في دالاس, please give us a call and we would love to have you here. And بعد الليكشر ده برضه I'm gonna give محمد عباس وأكرم my contact information. لو في زول يعني have any other question you want to discuss about something, I'm here. Any question, guys?
يا حسام، في مستر علاء الدين نقد، بعدين مستر تامر عندهم فرصة. تفضلوا. بعدين في زول رفع يده قبل برضه بس نزل ما انتبهتوا كاملوا. تفضل يا مستر علاء.
طيب يا حسام، أول حاجة thanks for the nice presentation. طيب في sometimes بيكون عندك patients who have a huge necrosis و they are not responding well للconservative management attack, especially phase 1. I faced like 2 or 3 patients that you try to delay the surgery as much as you can, لكن بيكون more than 50%, sometimes like more 60%. And هنا I was enforced to operate. صراحة النيكروسكتومي بتكون difficult لأنه ما بيكون في demarcation and you're just removing just like a mud يعني من البانكرياس. لكن I think that saved them life. وصح هنا ده أنا I was forced to do a programmed stage necrosectomy. يعني patient I have entered like 3 or 4 times, one of them. I received the patient can بعد 11 days. Do you have an experience of like intervening early? طبعا I don't know انتوا حيكون عندكم IR, لكن هنا I was forced to do an open necrosectomy early on, remove some of this mud. لكن صح from the first time I know that I will going to enter again.
اوكي مشكور يا مستر. اظن عشان نتكلم عن حاجه، عشان نرد على السؤال ده، اظن انه يعني المفروض نحدد حاجتين. الحاجه الاولى المفروض نحددها do I intervene or not. السؤال اللي بعده how do I intervene. بتفق معاك تماما. You try يعني do I intervene or not. You intervene for infected necrosis في phase 2. Phase 1 you intervene if the patient is not getting better. لأنه ده معناه واحد يا العيان حصل له one of the patient who has an early infection في phase 1 happens sometimes. يا العيان ده عنده severe SIRS reaction and is just not responding. Okay. Yeah, we have misdiagnosis. عندنا حاجة ثانية. عندنا perforated intestine, عندنا ischemic intestine, عندنا another diagnosis. في phase 1 دي الحاجة اللي تخليني to intervene ودي الحاجة اللي خلتك to intervene. فالquestion is when do I intervene or not? انت كنت في phase 1 لكن you're faced by a patient who is not getting better. He's failing to improve. If you don't do anything, that patient is gonna die. فأنا بتفق أنا وأنت الاثنين حنتفق في إنه yes, we're gonna intervene in this patient. الاختلاف حيجي how to intervene وما اختلاف بتاع آراء، اختلاف بتاع logistic support. الفرق إنه أنا عندي intervention radiology available my go-to is gonna be percutaneous drainage. But if you do not have a percutaneous or an interventional radiology option, you cannot go back and say I'm not going to intervene. So I think that to be systematic and think about this, you always have to ask yourself so you don't get confused. إنه الناس هناك بيعملوا endoscopic drainage، ده هنا بيعملوا IR. You have to ask yourself, do I need to intervene? If the answer is yes, then you have to choose whatever approach that you have available that you think is the right thing for that patient and your care and use that. So again, in phase 1, if the patient is not improving, not progressing, the patient is burning and crashing, either the patient truly has an early infection, one of the few patients, or the patient has very severe SIRS reaction that's just not responding, or we have another misdiagnosis. ودي الحاجة مثل اللي أنا بعملها هنا في العيانين ده الفيديو غالبا تحصل في the first week or 10 days or so. Video very sick, severe SIRS reaction, and they're not improving. Regardless of what I do, they're just not improving. I do a CT scan, a lot of fluid collection, and I drain them percutaneously. And again, I don't even go after the necrosis. I don't even look how much pancreatic necrosis they have, 30%, 60%, because a lot of time it's the cytokines in the fluid around the pancreas. And a lot of time when you drain that fluid, you decrease the cytokine burdens and they improve, and they'll give you a chance to fight another day with the programmed necrosectomy in your case.
Mr. Tamer.
Assalamu alaikum. Thank you, Dr. Osman, actually, for this presentation. It was so informative. I want to speak about 2 points. The first one is a comment, the other one is a question. The first point, actually, I had experience actually with one patient that I have attempted retroperitoneal, left-sided retroperitoneal necrosectomy on a drain, which had been subsided actually to the level of the French 22 French chest tube. We put a scope and we tried actually to pull actually the pancreas from this area, the necrotic pancreas actually from this point. And then unfortunately I got the torrential bleeding. We succeeded at the end to back it, and then we did radio embolization at the end. And fortunately it goes fine after very prolonged length of stay of the patient. The other thing, actually, the question is about the persistent pre-pancreatic fluid collection, or you could put it in bracket of open and close of pseudo cyst. I'm asking about the proper timing, actually, of drainage in the form of cystogastrostomy. I know that there is a rule of 6 for it, but I have one of the studies that's showing that if you could wait enough, okay, I gave them about 12 weeks instead of the 6 weeks, the proper timing of the maturity actually of the wall. And in the study that it showed that 74% of this patient, they don't need even a kind of drainage for this. And just I'm asking about this point, about your proper timing actually for the cystogastrostomy. Thank you.
مشكور يا مستر. النقطتك الأولى أظن بترجعنا لأول حاجة تكلمنا عنها، إنه the beauty of pancreatitis, the beauty of having a center or having a program to manage pancreatitis, it will force you to get better. لانه انت هسه عين انت مشيت الاو ار، استعملت intervention radiology for during placement، استعملت intervention radiology for radio embolization. يعني الناس لو اخذت management of severe pancreatitis as a program or initiative or project, it will force you to have a good lab for your blood work. It will force you to have good IR, OR, GI, intervention radiology, everything radiology. So it will really help elevate the entire hospital or institute. بالنسبة للنقطة الثانية تحت التايمينج for cyst gastrostomy. First of all, I don't use size at all. I don't look at the size. I look at symptoms. الحاجة اللي داير أذكرها في الحتة دي يا مستر إنه when I see them, and usually العيانين دي غالبا they're phase 3 or what we can call that early phase 3, meaning that they left the hospital. أظن بيتكلم عن العيان إنه they likely left the hospital and after their severe pancreatitis, mean a surge or organ failure and all that, and they got better, and now they're coming back with symptoms: abdominal pain, discomfort, nausea, and vomiting. في الحتة دي أنا يعني الحاجة the way I like to look at this is I try to know, are their symptoms pancreatitis related or are their symptoms mass effect related? Pancreatitis related, meaning that I believe they have recurrent pancreatitis attack. And in that case, I think about structural damage of the pancreatic duct. I get an MRI to see if they have a disconnected duct or not, okay? And their symptom is gonna be typical pancreatitis. Here they describe sharp pain that goes straight to the back or maybe a little bit to the left side. While the mass effect, their symptoms are mostly dull pain in the epigastric region, a lot of nausea and vomiting, and inability to tolerate food. The reason I try to differentiate, because if I believe their symptoms are recurrent pancreatitis, I know I have to do something for that. Draining the collection alone may do the trick, but I have to think this is going to be a temporary fix, meaning that I have to be prepared. This patient may need a distal pancreatectomy in the future, or a pancreatic drainage procedure, PSO or something, because they have a structural damage of the pancreatic duct, either a disconnected duct or a stricture. Okay. When their symptom is mass effect, dull pain, nausea, and vomiting, then all I need to do is to drain the fluid. And when they are overall doing well, this is the situation where I do not drain them percutaneously. Then if you drain them percutaneously, you end up with a drain and a pancreatic fistula. We buy that in phase 1 and phase 2 because the patient is very sick. But now we're moving to a patient who's otherwise normal apart from this local complication. These are the patients that I take them for cyst gastrostomy, either endoscopic or surgical. So I go by the symptoms. I don't care about the size, whether it's 6 centimeter or if it's 20 centimeter, which is unlikely to have 20 centimeter, that's asymptomatic. But to exaggerate, regardless of the size, if they're asymptomatic, I don't touch them. I only intervene for symptom. That's why I don't even do a follow-up CT scan, because I only do it if they're symptomatic. So I intervene for symptoms, and time I would like to wait after 6 weeks. And because I'm intervening for symptom, that's why after 6 to 8 weeks, I have to intervene because they're symptomatic. If they are not symptomatic, or if their symptoms are not that bad, I would wait, because a lot of time they will surprise you. As you said, after 12 weeks or so, you do a CT scan and bam, everything is gone. But then they may develop some structural damage. But the point is that, are we dealing with recurrent pancreatitis or are we dealing with mass effect? You differentiate based on symptoms, and then you do your imaging workup to delineate that, okay? If it's mass effect, you intervene only if they're symptomatic, regardless of the size. I would like to wait at least 6 weeks, and their symptoms is what will determine when do I intervene, not the size, is their symptom. If they're very symptomatic, I have to go at 7 weeks. If not that symptomatic, I wait with the hope that it's going to go away. Hopefully that answered your question, yeah, Mr.
Mr. Muhammad Abdullah, bariatric surgeon, welcome.
Thank you, Dr. Houssam, for this nice lecture. Maybe I missed part of it. Just عندي سؤالين. When to restart feeding? Maybe يمكن تكون ذكرتها في الليكشر. والحاجة الثانية question regarding the role of C-reactive protein in the follow-up of the patient, if he's improving or not. If you can elaborate about this. Thank you.
يديك العافيه مشكور مستر. بالنسبه للفيدنج we like early feeding as soon as possible and we prefer enteral feeding over parental feeding. We prefer to feed them as early as possible. And we talked about a study that compared early feeding 24-hour versus delayed early at 72-hour, and there was no difference. So likely by the third day or so, I like to start some form of nutrition. And I like to feed them through the gut. And if they can tolerate oral diet, can just feed them and they can handle it, I would start that. If they're intubated and they cannot eat, I'll try to use the NG tube for feeding. If they can handle that, great. Otherwise, I will use TPN. And we mentioned that the only time that I shy away from using the gut for feeding, if they are very sick and they are on high pressure requirement, because the fear of intestinal ischemia increasing blood demand in the intestine. النقطة الثانية C-reactive protein. You can use the C-reactive protein whenever you want. بالنسبة لي C-reactive protein is a prognostic factor, and زي ما ذكرنا يعني we like to use it to know where to place the patient and how to allocate the patient. And usually this is of importance in the first 48 hours. عشان تعرف العيان ده is the patient going to develop necrosis? Can I predict if this patient going to have infection or not? Do I need to put them in ICU? So we talked about this, about the use of C-reactive protein with SIRS, with other the Marshall and the Apache 2 and all that, whatever we think is appropriate and is easy to use in that area. So, and I think ده برضه برجعني برضه النقطة بتاعت محمد علي إنه every time we talk about any parameter we're using in pancreatitis, you have to know, are we dealing with a diagnostic parameter or are we using with a prognostic parameter? CRP is a prognostic parameter. The one thing that I see a lot of people here in the United States, they do a lot, is they use lipase. Lipase has no prognostic value. Lipase and amylase are only for diagnosis. Meaning, patient presented, lipase of 2000, you made the diagnosis of pancreatitis. Lipase tomorrow is 0, it doesn't matter. Lipase tomorrow is 5,000, it doesn't matter. Lipase is only for diagnosis, has no role for determining severity or predicting outcome. C-reactive protein, on the other hand, does not diagnose the infection, it predicts the chance of the infection happening or having necrosis or severe course. And you can use it whenever, but practically you need that in the first 3 days or so to determine where you're gonna place that patient.
في سؤال من دكتور إيمان بتسأل if the pseudocyst decrease in size, what was communicating with the duct? What is your approach?
Communicating with the pancreatic duct?
Yes.
Okay. So the question, if we have, so now we're talking about a pseudocyst or likely a walled pancreatic necrosis that in the delayed phase, the patient has passed the sick phase, and now they're presented with a symptomatic mass effect symptom from walled pancreatic necrosis or pseudocyst that is communicating to the pancreatic duct. Is that the question?
Yes.
Okay. So my approach is cyst gastrostomy, either endoscopic or surgical. In this patient, I would avoid percutaneous drainage because percutaneous drainage in this patient will buy you a pancreatic fistula. Again, we're talking about a patient not in phase 1, not in phase 2. We're talking about a patient who has survived all that and went home and now is back with just a symptomatic local complication from walled necrosis. So that patient is going to have an endoscopic versus surgical cyst gastrostomy. What determines which approach I'm going to use is one, how much necrotic material do they have? Okay, so I do an MRI. If they have more than 50% necrotic material, I'm going the surgical route, okay? Unless I have a really good GI who can do necrosectomy. If it's true pseudocyst, meaning that, and we said pseudocyst happen without necrosis, then I go straight for the endoscopic approach, okay? And the reason I go for the cyst gastrostomy and the debridement, if there's more than 50% necrosis, because I believe their symptom can be a combination of mass effect from the fluid collection and recurrent pancreatitis and ongoing pancreatitis from the presence of the necrosectomy, of the pancreatic necrosis. in this patient, you have to keep in mind that your approach, whatever approach that you're going to use, will likely work. But you have to keep in mind, this patient eventually may develop that connection to the pancreatic duct, may eventually heal with stricture, and they are going to present with left-sided recurrent pancreatitis that will force you to do a distal pancreatectomy. And when you go to do distal pancreatectomy, you do not have to violate your cystgastrostomy. You just stop right at the level of the cystgastrostomy and take all the left pancreas, the body and the tail, along with the spleen. Don't leave the spleen because you're going to end up with a splenic vein thrombosis and sinistral hypertension eventually.
دكتور محمد علي, you're welcome.
مستر انا have few questions كده يا ريت تصبر علينا الليله طولنا عليك.
اتفضل.
الحاجه الاولى اللي عايز اسال منها بالنسبه لللونج تيرم فولو اب for these patients, هل في فولو اب بروتوكول واضح يعني imaging clinical parameters بس ورينا الفولو اب اللونج تيرم فولو اب, وحاجه تكون ما حاجه مكلفه لكن تكون حاجه يعني available عندنا هنا, we can do it very easily, very simple to follow these patients. دي الحاجه الاولى. الحاجه الثانيه suppose في patient كان عنده pancreatic pseudocyst without necrosis, not infected but communicating with the doctor. The best investigation انه to يعني to see the anatomy of this duct, pancreatic duct بالذات. Is it endoscopic ولا CT is enough؟ السؤال الثالث, معلش انا حاسس بكلف.
ولا يهمك. قاعد تكتب الاسئله دي, عرفت انه ما عندي ورقه عشان ما نضيع اسئله محمد علي دي.
طيب ده الكفايه خلاص.
لا قول الثالث, ده انا مذكرهم, قول الثالث.
خلاص قولهم لحد ما بعدك تخلص غير ونشوف.
اوكي جدا. طيب السؤال الاول كان انه الفولو اب. اذا احنا نتكلم عن patient I am confident انه I am not missing a cystic neoplasm and I'm not missing a malignancy. نتكلم عن biliary pancreatitis, alcoholic pancreatitis, whatever. Once they recover, I'll follow up clinical. I don't get a CT scan. I don't do repeat imaging at all unless they're symptomatic. The reason is a home not symptomatic, I am not going to intervene. Meaning that, let's say that I see them after a year. I do a CT scan and I see residual fluid collection throughout the pancreas. And they're asymptomatic, I'm not going to touch them. I only intervene for symptom. That's why I only do a workup if they have symptoms. Asymptomatic, clinical follow-up. Then for clinical follow-up, if they تعرف do they have symptom or not, معناه are they developing recurrent pancreatitis or they're progressing to chronic pancreatitis. That تعرف هل do they develop diabetes or not, are they diabetic or not. That تعرف if they develop exocrine pancreatic insufficiency or not. دي الحاجات اللي بتخليك you can يعني manage them. بيخليك يا انه with diabetes you might diabetes, with exocrine pancreatic insufficiency they will need pancreatic enzyme supplement so they don't lose weight and yada yada yada. If they have recurrent symptom, this is when you start your workup to determine if you need to intervene and how to intervene. But I do not do follow-up imaging if they are asymptomatic. I do clinical follow-up. The imaging workup will happen if they develop symptoms. Okay. السؤال الثاني عن the best way to delineate the anatomy of the pancreatic duct is the MRI. MRI with and without contrast is the best way to delineate the anatomy. If you want to be very specific and see the function of the duct, you can do a secretin stimulating MRCP. You give them secretin and you do an MRI and before and after the secretin, and it will show you the response of the pancreatic duct. If the duct does not move, then they have chronic pancreatitis, and it will tell you there is stricture. So this is the best way to identify anatomy is MRI. Okay, best is MRI with and without contrast, and after that is secretin stimulating MRI. سؤالك الثالث شنو يا محمد؟ If I answer.
you answered it. لكن بس عندي حاجه برضه في الحاجه. طيب اذا البيشنت مثلا كان خاشي فور نيكروسكتومي multiple procedures وكده it's not important for you انك انت مثلا to delineate the anatomy of the duct. ما حصل اي complications, ما في fistula, ما في كده, ما ضروري يعني to do إذا patient asymptomatic
تتكلم pre-operatively or post-operatively؟
يعني مثلا طيب في patient كان post-operatively جاء وخش مره بالفيز دي وبعد ذلك بقى فور سيرجيكال انترفنشن وخش الانترفنشن وتعمل له نيكروسكتومي باي واحده من الطرق دي وكده. After that في الفولو اب mandatory for you to do MRI to see.
Nope. Is he symptomatic or not?
Asymptomatic.
Nope. There's no intervention for asymptomatic pancreatitis patient. What are you going to do? Let's say that you do an MRI and you see a mild stricture in the pancreatic duct, and he's asymptomatic. Are we going to intervene? Nope. So we only every time you do surgical intervention, you have to ask yourself why you're intervening. In surgery in general, you intervene to prolong life and to improve quality of life, regardless of the CT scan finding. العيان ده جاك asymptomatic. Okay. But if you do any intervention, are you going to prolong their life? The answer is no. Are you going to improve their quality of life? They're asymptomatic. How are you going to improve their quality of life? So if I'm not going to intervene, why ask the question? I only ask the question if they are symptomatic because I want to do something to improve their quality of life. Does that make sense, Muhammad?
ايوه تمام. طيب اليوزنج اوف اوكتيريوتايد انا ما اعرف لكن الموضوع ده زي الفيو ديبيت في ناس they use it في ناس they don't. انت with your own experience when the use of the octreotide is a must.
Okay. بنتكلم عن use of octreotide in management of acute pancreatitis ونتكلم عن octreotide to decrease pancreatic fistula. دي حاجتين
في الacute pancreatitis.
Okay. في acute pancreatitis I don't use it. مع انه في two reports يعني they have really good outcome with using high dose octreotide. A low dose octreotide did not make a difference. A high dose octreotide seemed to have make a difference. It's not a level 1 evidence. أظن عشان كده is not adopted. أظن محتاجين just more studies to really confirm that. لكن حاليا يعني it's not something that is widely used. It's more of an academic thing, if you will. But octreotide here is not used on a practical level. I only use it for pancreatitis patient if they develop fistula. Like let's say it's not even a fistula to the intestine yet. If they develop a pancreatico-pleural fistula, and again, I'm not talking about decreased pancreatic fistula after a Whipple procedure or a pancreatic anastomosis or after a pisto. I'm talking about a fistula that happened after pancreatitis. If they develop pancreatico-pleural fistula, this is the patient that I would use octreotide to decrease the pancreatic output. Even if they have a drain and they have a pancreatic fistula, if I'm going to use octreotide, I'll usually use it because the patient is not a good candidate for surgical intervention. And then I'll be very aggressive in terms of MPO status, TPN, and octreotide. So I rarely use it while the patient is eating. So if I'm going to use it for pancreatic fistula, again, it's either pancreatico-pleural fistula or a pancreatico-cutaneous fistula, and the patient is not a good surgical candidate, and I would do an MPO and TPN in addition to octreotide to completely rest the pancreas to see if the fistula will close on its own.
Thank you, Mr. شكرا جزيلا. It was very nice presentation, nice lecture. ويا حبذا لو تكرر وقت كثير.
يديك العافية محمد.
تسلم أستاذ. يديك العافية.
ممكن نسمع مشاركة من سليم لو موجودة معنا.
السلام عليكم.
السلام.
أول حاجة يعني حنعيد الترحيب مرة ثانية وشكرا جزيلا على الليكشر، كان مفيد جدا جدا. يعني إحنا طبعا قاعدين في زي ما قلت لكم في المملكة العربية السعودية، قاعدين في المنطقة الجنوبية. لو جينا نتكلم عن الليكشر من البداية، مبدئيا عندنا high availability of CT scan وكل الانفستيجيشن CRP is done on daily basis. البيشنتس حتى إحنا ممكن نقول إنه في abuse للCT scan، فإحنا لما جينا بدينا نعمل بروتوكول للبيشنتس بتاع البنكرياتايتس، لأنه هنا ده عندنا very high incidence of gallstone disease and gallstone pancreatitis بصورة يمكن أكثر ما شفناها كتير جدا في السودان. بس الحالة الكويسة إنه في معظم الأحيان بتكون mild to moderately severe pancreatitis. يمكن there was only one case of really severe pancreatitis young patients that eventually died of severe pancreatitis. Anyway, كل ال facilities available, ICU is ready زي ما انت قلت within 5 minutes you can transfer patient to ICU. البوتtom لاين يمكن الكومبليكيشن ريت is different. الحاجه اللي لاحظتها بين السودان وبين هنا، في السودان هناك يمكن تقول لقيتنا عدد من الكيسز بتاعت السيفير بانكرياتايتس necessitating some sort of intervention اللي هو radiologically دايما بيكون بسيط جدا لكن usually surgical intervention. فهنا السبيكترم of the disease is partially different. and I know انه انتوا so much interested في السبيكترم of the disease في السودان وال available investigations. Anyway, and I find it very useful إنه clinical picture is the most important في كل patients. فمثلا suppose إنه you have a patient with severe pancreatitis. You think in this severe pancreatitis, if the patient is having like a tachycardia and you have full fluid resuscitation and adequate pain control, if the patient remains tachycardic, most likely this patient is having pancreatic necrosis. ودي بتمشي مع يعني في جزء من السكورينج سيستم بتلقى انهم بيعتمدوا على الكلينيكال بيكتشر في يعني يمكن دي الحاجه المشتركه بيناتهم جميعا. In addition to some parameters to show يعني الفلويد shift during the attack of pancreatitis and the degree of bleeding. عشان كده بنلقى مثلا في الرانسوم في البي سي في والاماونت اوف فلويد يوز فور resuscitation كده. زي ما قلت كبير انه if you find too many systems for classification or too many types of operation or too many techniques for a certain operation, that means none of them works perfectly. فشكرا لك، شكرا جزيلا، وكان very nice one، ويعني ممكن اقول احنا كلنا استفدنا منه كثير. شكرا جزيلا.
يديك العافيه دكتوره، انا 100% agree بكل الحاجات اللي قلتيها. اظن المسج في السودان انه يعني اللكشر والحياه الناس اللي معاك سواء بيتعامل هنا في السودان او في السعوديه ما عشان الناس تطبقها بحذافيرها، لكن عشان تشوف الحاجه اللي ممكن تترانسفير ذات نولج في السودان. حاجتين، انه تشوف الحاجه اللي ممكن حاليا تستعمل في السودان، او الحاجه اللي تشاف انه this can change really patient outcome and decrease mortality فمفروض نعملها في السودان. فزي ما انت قلتي في مليون clinical scoring system، عشان كده يعني I did not adopt any one of them لانه ما في واحد بيشتغل. and at the end of the day زي ما قال الدكتور حتلقى انك انت يعني you're using your clinical judgment a lot of time. and the most important thing is that you understand the logistic support that you have and how much risk can you take and are you and can you salvage your mistake. if you يعني في السودان I'm going to prefer to over triage the patient. يعني بيكون احسن انه we may abuse the system. Again, it's the question of do you over, because it's very difficult to triage correctly all the time. So we lean toward over triaging, lean toward under triaging. With trauma مثلا, we always lean toward over triaging the patient because we don't want to miss a disaster. Okay. في pancreatitis عندنا هنا مثلا في tertiary center حقنا, when they hit the emergency department, we tend to under triage لانه عارفين we can go up at any point and we don't want to overwhelm the ICU. لكن غالبا في السودان يعني if we adopted a protocol غالبا حيكون something similar to trauma to over triage and be a bit more aggressive. This is what I would think.
برضو في one point انا هضيفها ليك معلش يعني، لكن مثلا احنا هنا CT scan بقينا we do not use CT scan unless the patient is not improving after 3 days. يعني رغم انه ممكن تكون مختلفه شويه لان احنا most of the patients are young patients. الحاجه الثانيه most of the patients at one time of their life بتلقى مثلا السنه اللي فاتت عملوا CT لانه زي ما قلت لكم في extreme abuse of the CT scan. فبتلقى انه البيشنت مثلا خلال السنه اللي فاتت جا شكى مثلا من abdominal pain any regular abdominal pain ان شاء الله كان gastroenteritis، تلقى انه زرع عملوا CT scan. فاحنا بقينا خلاص بيادوبت انه اي الكوليسترول pancreatitis do not do CT on admission. We diagnose them with the clinical picture and the serum amylase, and afterwards if they do not improve after 3 days we do CT scan. فبالتالي انت في السودان you do not need to kill yourself to get a CT scan on the spot، خاصه انه الCT scan الريبورت بتاعنا لو اذا كانت نفس السيتويشن اللي انا كنت هناك اللي هي زي 9 شهور قبل 9 شهور الCT will get reported after 4 days. تكون وصلت المرحله الثانيه.
والحاجه الثانيه الCT scan ذاته يعني on presentation is likely going to miss the necrosis. يعني عملت CT scan on presentation and it did not show necrosis، ده ما معناه patient that does not have pancreatitis
ما عنده ولا هيحصل.
and this is the reason انه حاليا people يعني they moved away from using CT scan for diagnosis. I 100% agree.
Thank you very much.
طيب يديك العافية شديد يا مسريم. طيب قبل في جالاكسي A7 2018. أنا ما عرفت الاسم بس كان على اليد مرفوعة. لو في سؤال ولا مشاركة، واي ثينك احنا بعد ده ممكن يعني المشاركة دي وبعدين يمكن واحدة ثانية بالكثير، واي ثينك ممكن نختم لو الناس ما عندها مشكلة. تفضل.
اوكي، انا كنت سألت في الشاتنج عن الميثودز اللي احنا بنستخدمها في الصدام في السيفير كيسز.
تفضلي، ممكن تسألي فيربالي طوالي. تفضلي.
ما هي بس السيفير كيسز احنا ويوز مثلا البابوتا، يوز الميثودز دي. وكنت سألت عن انه عايزة انه جالس الليكتشرز بتاع يعني البرنترال.
الصوت ما واضح يتخيل.
انا ما سمعته والله، معلش.
لو بس حبيتي تعدلين السؤال تاني دكتورة. أنا قبل قريت في الشات كنت بتسأل من بابجوتا باك as a method، وتاني قلتي برضو method تانية washing and out methods. بس لو قدرت توضحي أكتر سؤالي يكون ما قصرتي.
تخيل لي في مشكلة في الكونكشن.
عندك فكرة يا محمد عن انه سؤالك كان عن شنو بالضبط؟ يعني لو انت قلت.
لا ممكن هسه هي تشاركنا ثاني من جديد.
اوكي تمام.
طيب أنا حدث فرصة لي مستر تامر لغاية ما دكتورة ترجع. أنا ما عرفت اسمه معلش. تفضل يا مستر تامر.
By the way, I guess maybe she's asking about the Pagoda bag with the acute compartment with acute pancreatitis. I think this is her question actually, not set at the beginning of the chat. Anyway, I have a comment actually about the CAT scan and the timing of it. We mostly just doing the CAT scan mostly after a week from the presentation. I don't like actually to do even a contrast CAT scan in a patient with acute severe pancreatitis with the possibility of acute renal injury, and this is going to worsen the thing, and even the amount of information that could help me in the prognosis of this patient will not be clear actually within the first week. Thank you very much.
اتفق معك. بالنسبه للسؤال بتاع اليوز اوف whatever closure device في الكومبارتمنت سيندروم، اظن تاني بيرجع لحته اتكلمنا عنها، انه اي intervention عنده two aspects. Do I need to intervene? And if yes, how do I intervene? النقاش في الابdominal compartment syndrome في early phases of severe acute pancreatitis, we're talking about the first 72 hours or so. The question is, do we need to intervene? Okay. يعني numbers will tell this patient has abdominal compartment syndrome, yada yada yada. The problem is that the pathophysiology is the SIRS, is not the abdominal. They're not going to die because they have abdominal compartment syndrome. They're going to die of the SIRS reaction systemically. فعشان كده الكويشن الاختلاف انه do we even need to intervene؟ يعني حتى when we intervene في العيانين ديل بالabdominal compartment syndrome, it's in the intensive care unit. We open the abdomen, and what device we have here is called the Apthera-Vac. Just like a plastic bag, we put it on top of the abdomen connected to suction. أظن الكويشن في abdominal compartment syndrome for severe pancreatitis is not how to intervene. أظن الكويشن is, do we need to intervene? Is decompressive laparotomy, regardless of what you do, going to change their outcome? الاختلاف إنه أنا هنا بقى عندي, if I feel like yes I have to intervene, then my intervention is going to be an early percutaneous drainage to drain the cytokines, CVVHD, continuous dialysis with diuretic, pulling fluid, and paralyzing the patient on the vent.
تسلم شديد يا حسام. I think احنا we are hitting the 2-hour mark here. فأنا ما دار أمسك بالزمن، نسيسم فرص الأسئلة كثيرة، والموضوع طبعا متشعب وكبير شديد، لكن بس داير برضو دي فرصة للناس إن السودان الساعة بقت 10:15 بالليل. فحابب بس أشكر الناس كلها. دكتور حسام عثمان يديك العافية شهيد المحاضرة. شكرا بروفيسور إيمان حسين مستر علاء، مستر تامر، نسرين، وكل الدكاترة الأفاضل والحضور اللي شاركوا معنا الليلة. إذا عندكم أي أسئلة أو أي كومنتس ثانية ممكن ترسلوا لنا في أي وقت عن طريق محمد عباس أو دايركت، وبرضه حنخلي الكونتاكت انفورميشن بتاع الدكتور حسام مع محمد عباس لو في أي زول عنده أسئلة أو كومنتس أو أي حاجة محتاج فيها أي شيء. we are looking also at your comments. الليكشر إن شاء الله زي ما عارفين ريكوردد، وحنكون محمد عباس حيرفع عليكم في اليوجوال جروب زي ما الناس بتشوفها دائما. شكرا لكم جزيلا ثاني، ونختم على كده إن شاء الله إلى لقاء جديد. السلام عليكم.
شكرا جزيلا.